Good afternoon and good morning, folks. Welcome to today's webinar, Medicaid Nutrition Supports Implementation Innovations. My name is Tricia McGinnis, and I am the Executive Vice President and Chief Program Officer at the Center for Healthcare Strategies, and I am so happy to get us kicked off for today's webinar. I want to thank our funding and thought partners in this work, the Kaiser Permanente Community Benefit Fund at the East Bay Community Foundation. This webinar is part of the Health-Related Social Needs Policy Formation and Implementation Learning Series. Next slide, please. For those of you who may not be familiar with the Center for Healthcare Strategies, CHCS is a nonprofit based in New Jersey. We work with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults who are served by Medicaid. Since 1995, we have worked in every state in the nation. We partner with states, federal agencies, health plans, providers, community-based organizations, and consumers to make healthcare work better for people who face serious barriers to well-being. Barriers like poverty, complex health and social needs, and systemic racism. We work to advance more effective models for care delivery, more efficient policy and program design, and across all of our work, we focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity for people facing the greatest health disparities. This webinar is part of a project, Health-Related Social Needs Policy Formation and Implementation Learning Series, which CHCS has been leading in partnership with the Kaiser Permanente Community Benefit Fund at the East Bay Community Foundation. As the name suggests, the project focuses on supporting states that are implementing coverage of services intended to address health-related social needs. In the past 5 years, we've seen a rapid acceleration among state Medicaid agencies using 1115 waivers, and more recently in lieu of services authorities to cover nutrition, housing, and other social services that can improve health outcomes. Starting with leading edge states like California, Massachusetts, New York, and North Carolina, and now expanding to over 25 states, a list that seems to be growing each day. But implementation is often where well-designed policies can falter and where peer-to-peer learning and sharing between states can be particularly helpful in making these policies as effective and improving health outcomes as we aspire to. Recognizing the opportunity for implementation support, CHCS launched the Health-Related Social Needs Policy Formation and Implementation Learning Series in 2024. This project brings together 9 states to share promising implementation practices, hear from implementation experts, identify solutions for overcoming challenges that they are encountering and in implementing these new services. And given that health-related social needs involve new types of community-based service providers, new ways of measuring impact, and very different types of services and payments than typical healthcare services, we have found this to be a really helpful forum for participating states, and we are very eager to share some initial implementation lessons with you all today. Next slide, please. So today's webinar, after we do some quick introductions, we're going to dive right in with a focus on what we are learning in the nutrition support space. We're going to start out hearing from some experts around the lay of the land, the policy context, and the existing evidence around food as medicine programs and the rapid cycle of innovation that's happening in this space. We are then really pleased to turn to our state panel, where Massachusetts and Michigan are going to share early lessons around implementing food as medicine programs in their Medicaid program space. And then we will save some time at the end for Q&A from the audience. Next slide, please. So if you're interested in submitting a question, please click the Q&A icon at the bottom of the screen, and those will pop up to the panelists, and we will take as many as we are able. Next slide, please. So I am really thrilled at this point to hand it off to Pam Schwartz, who is Executive Director of Community Health at Kaiser Permanente and has been a close thought partner to us on this program and an implementation innovator herself. So Pam, hand off to you for some opening remarks. Thank you.
Thank you, Tricia. It's super excited to be here. Good morning and good afternoon to everyone. And I am honored to be here to help kick off this next session in the Health-Related Social Needs Implementation Series on nutrition support. And as Tricia said, I'm the Executive Director for Community Health at Kaiser Permanente. And with that, I have the privilege to lead our Food as Medicine Center of Excellence. And we are working with a multidisciplinary team of clinicians, researchers, public health professionals to really more fully integrate food and nutrition into our care delivery model and more broadly across healthcare. So this topic of increasing access to healthy food in healthcare is near and dear to my heart. And I know I don't have to tell this crowd about the need, but just to get us started as we kick off the panel here, we know that poor diets are the leading cause of death in the US, with Americans with lower incomes and living in rural communities or from historically marginalized racial and ethnic groups most affected. Also, 1 in 10 Americans is food insecure, and 1 in 2 US adults have diabetes or prediabetes. Also, 18% of US healthcare costs from heart disease, stroke, and diabetes are attributable to unhealthy diets. There's also over 77 billion estimated in annual healthcare costs from food insecurity. But on the positive note, there is so much enthusiasm to partner across sectors to solve our nation's diet-related disease epidemics. And it absolutely makes sense that our nation's healthcare system would play a leading role in increasing access to healthy food. And the 1115 waivers, as Tricia mentioned, are a unique opportunity to really test innovative ways to care for our patients. And I applaud the commitment of the states participating in this series and the new ones coming on to really come together to share best practices and shape the policies to expand access to healthy food and other other essentials to our communities. And I'm grateful for the Center for Healthcare Strategies for creating these opportunities to really collaborate, share best practices, and improve the social services for millions of Americans. And maybe just for a little background about Kaiser Permanente's approach to social health, we know that even the very best medical care is only one ingredient to good health. And it's almost impossible to be healthy without a safe place to live, healthy food, strong social connections, and many other essentials. And so we've invested heavily in our social health practice over the past several years to really be able to better understand the social vulnerabilities that our members face and also to offer support through a vast network of community-based organizations and social service providers that exist in our communities. And so we opened Kaiser Permanente's Community Support Hub in 2023 to really bring greater coordination to this work and to more fully integrate social health screening and the support for positive screens, including support for social needs like housing, healthy food, transportation, utility bills, et cetera, into care and services that we provide to all of our members. And just last year, we launched Kaiser Permanente's Food as Medicine Center of Excellence with the intent really to transform the way we treat and prevent diet-related disease and hunger. And we know that social needs are prevalent across all lines of business across the nation, not just Medicare and Medicaid. And in a recent survey, we found that more than 2/3 of our members reported having at least one social need. And when we looked specifically at food, food and nutrition insecurity, we saw that 25% of our members and half of our members with Medicaid plans told us that they struggle with food and nutrition insecurity. So to give you just a flavor of what we've done so far, we use text and email to proactively outreach to our members we suspect might be eligible for government nutrition programs like SNAP and WIC to really offer assistance. And so far, we've helped over 140,000 members apply for those benefits. We're also building the evidence about the impact of food as medicine programs on patients' health outcomes, while also figuring out how to operationalize these interventions within the healthcare delivery through things like the 1115 waivers. And we have some early successes in these efforts. For example, a medically tailored grocery study among members with type 2 diabetes shows significant improvements in blood sugar levels after 6 months of intervention. And we have a study underway in partnership with Instacart to understand how increasing access to healthy food choices impacts health outcomes for those with diet-related disease. And these are just a flavor of what we've done. So just to conclude here, we know that there's a unique role for healthcare to be part of the solution for addressing food insecurity, but even more with diet-related disease. And this is new for many of us, and growing pains are natural as we collectively try and figure out how to bring something that is not inherently medical into the healthcare system, while also retaining flexibility in the model to allow for both choice, which our members are telling us they want, and consistency. This is especially important for multi-state providers and health systems like Kaiser Permanente, where delivering consistent care experience is a core business imperative. And so this requires new partners that we haven't played with in the sandbox before. It also requires new workflows for our providers, new payment mechanisms, as was already mentioned, and so much more. But there is so much enthusiasm for this work. I feel it every day from my own organization and also across the nation. So thank you for your dedication to this learning series. And I know there is so much innovation happening right now in the States, just some of which we're going to hear about today. And I think we can all be assured with the passion in this virtual room to innovate together to serve Medicaid members differently and to address the social factors like housing and nutrition insecurity that so powerfully influence people's health and the ability to access healthcare. So with that, I will turn it over to Amanda.
Thank you so much, Pam, and really appreciate you sharing those early implementation lessons. And just thank you so much for your and Kaiser's leadership in this space. We greatly appreciate it. I'm going to hand it over to kick us off with today's presenters. My colleague Amanda Bank, Program Officer at CHCS, is first going to give a little bit of policy context, and then we're going to hear from Kevin Wolf, Director from the Penn Center for Health Incentives and Behavioral Behavioral Economics, and the scientific lead for the American Heart Association Healthcare by Food Initiative. Amanda, take it away.
Amazing. Thank you so much, Trisha and Pam. My hope is to provide you all with a snapshot of this moment in time as it relates to food security and Medicaid to really ground the rest of the webinar. So we can go to the next slide. And then one more slide. Perfect. So as you can see on this timeline, since January of 2021, there's been a ton of interest and momentum from the federal government encouraging state Medicaid agencies to address individual social needs, particularly food and nutrition insecurity. Now, I won't read out every item on this timeline, but I will take a moment to highlight that as a culmination of all of this recent federal guidance since 2021, in November of 2023, CMS published a framework outlining the distinct health-related social needs, services, and supports that are considered allowable under different Medicaid and CHIP authorities. So essentially, this was CMS pre-approving certain HRSN services for states to cover, and these were under the categories of housing, nutrition, and case management. And then last month, in December of 2024, CMS provided some updates to that framework based on some early implementation experiences and feedback from states. So, as a result of all of this encouragement, state Medicaid agencies across the country have begun offering these HRSN benefits, as Trisha and Pam both alluded to. And in the past month and past 24 hours alone, 12 HRSN-related 1115 waivers were either approved, amended, or extended by CMS. Of course, we know a new administration is imminent, and we don't know if there will be additional guidance or interpretations coming from the federal government in the coming months. But again, this is really just a snapshot of this moment in time. Next slide. So as listed in that CMS HRSN framework, states can cover nutrition services as benefits through any of the authorities listed here, those being managed care in lieu of services or settings, also known as ILOS, HCBS authorities, Section 1115 demonstrations, and CHIP health services initiatives. And the nutrition services that are covered in that framework include nutrition case management services, nutrition counseling and instruction, home-delivered meals or pantry stocking, medically tailored meals, and nutrition prescriptions. So these services, also known as food as medicine services, really aim to recognize that intrinsic connection between healthy food access and health outcomes. So again, these services are not aiming to duplicate other federal food support programs like SNAP, but rather complement them for folks with specific clinical and social risk factors. And we can go to the next slide. And with that, I will pass things off to Kevin Volpe, who will dig into the existing evidence around this food as medicine work and talk about the rapid cycle of innovation. Thank you.
Thank you, Amanda, and thank you to CHCS for hosting this and for all of you for being here. Let's jump to the next slide. And then let's go one more slide. I was asked to comment on three things: why food is medicine, what are some key findings from the field and gaps in evidence, and what is rapid cycle innovation and how could it be used to learn faster what works. Going to the next slide. We, in essence, as a country, are at a really critical juncture to recognize we need to find more cost-effective ways to improve health. There are lots of indicators of this. We rank last on key healthcare measures compared with other high-income nations, despite spending more on healthcare than any other country. And we are first in spending, 48th in life expectancy, obviously considerable room for improvement. Going to the next slide. Furthermore, we all know that food is central to health outcomes, and you can look at a lot of different organ systems throughout the body and see the clear relationships. Going to the next slide, Americans have very unhealthy diets. Only 1 in 10 meet recommended fruit and vegetable intake. More than 9 in 10 have excess sodium intake. Less than 10% eat enough whole grains. We know about obesity rates having tripled in the last several decades. And one really critical point to underline here is an estimated 45% of deaths from cardiovascular disease, stroke, diabetes are associated with suboptimal diets. So this is a major opportunity, a major challenge where we need to figure out how to do better. Going to the next slide. One of the key things to recognize is affordability is a significant challenge for many Americans. A recent survey done by the American Heart Association along with Deloitte and Research America found that 77% of Americans would like to have healthier diets. They recognize this is important, but the top barrier is the cost of healthy food. And disturbingly, more than half indicated that it often happens that children are eating cheap, unhealthy food so families can pay their rent, and that seniors are making these trade-offs between paying for prescription drugs or paying for healthy food. Going to the next slide, one of the important questions for us to recognize is where is there strong evidence? And there's so many different examples we could give, but I'm just going to highlight a couple of the most important studies. This study led by Seth Berkowitz highlighted, I think, the real potential for programs such as medically tailored meals in high-risk populations. So they found in looking across a pretty wide population that medically tailored meals could significantly reduce inpatient admissions, reduce skilled nursing facility admissions, and significantly lower mean monthly costs. This lays out, I think, very nicely what the promise is. Going to the next slide, we also have some very good evidence from small-scale trials, such as the Scott Hummel trial, that it's possible for a food as medicine program to significantly lower readmission rates. As a secondary outcome, Alan Go et al. At Kaiser found a pretty big difference in 90-day readmission rates for patients with heart failure in a recent medically tailored meal study as well. But going to the next slide, one of the things we found in carefully assessing the literature is there was a lot of small-scale studies. Many of them are underpowered, and there's actually very little in the form of large-scale testing of what is effective in practice and what has been implemented and disseminated. And I think this is an enormous opportunity for the Medicaid program to really both contribute to what is known and figure out what is the best use of dollars to improve people's health through food as medicine programs. Going to the next slide. there's a number of key questions that need to be answered to really define covered benefits and figure out where can we most improve people's health through food as medicine programs. We have a good start on this, in particular from the WIC program, but also what I just alluded to with medically tailored meals, from produce prescriptions, medically tailored groceries, on diet quality and food security, but lots of key questions here that have not been answered. What is the optimal intensity, duration, delivery? How do we optimally engage people initially? How do we help people change their behavior or form healthier habits? What is the role of coaching and other supports? What is effectiveness in settings where these can be scaled? And ultimately, another key question is going to be, what is cost effective for whom? Going to the next slide. One of the key things for us to recognize is the health system hasn't really tried to systematically increase healthy food access for high-risk people. And that's one of the big opportunities that's now in front of us. And the Medicaid 1115 waivers create a big open doorway to try to do that in the 12 states that have approvals. Next slide. In thinking about this from the Heart Association's perspective, as we took stock of the literature when we launched our initiative about a year and a half ago, it is important to recognize that providing healthy food at lower price through subsidized or free healthy food is critical. That alone is not going to lead to the kinds of improvements in health that we're looking for, because we see there are challenges with engagement. I'm not going to go through these statistics, but it highlights that doing some A/B testing, and I'll talk about rapid cycle innovation in a moment, of alternative ways to increase uptake and engagement is really key to these programs achieving their full impact on health and healthcare costs. Next slide. Another recognition is we need to meet people where we are. So we've thought a lot about human-centered design and the lived experience, really important as you think about what you might want to do in your states. We also want to think about how do we use behavioral science and what's known about how to motivate people, how to most successfully use incentives and apply that knowledge. We also think there's a lot of value where possible in using rigor in testing, and I'll talk more about that in a moment. Next slide. And then finally, another key principle to think about as we move from being a country which is first in spending and 48th in life expectancy, with a lot of challenges in terms of access to healthy food for people with diet-related chronic conditions, to a hoped-for vision where high-risk people with diet-related chronic conditions who can't afford healthy food have insurer support, is we are in a phase now where we can do a lot of testing and really figure out what works, so that as we move to larger scale testing, those larger scale tests will be more likely to be effective. Next slide, please. The AHA currently has 25 studies in the field. 23 of these are RCTs around the country, looking at a lot of these questions about implementation and trying to engage people at higher rates. Next slide. We are focusing on populations which we think will benefit most from food as medicine: cardiometabolic, heart failure, pregnancy, low-income food insecurity. Next slide, please. And we have a number of collaborators around the country, both corporations, as highlighted in this slide, and next slide, a number of community-based organizations. Next slide. What I want to close with is talking a bit about within-state rapid cycle testing, because I think this is really a key topic to dig into in terms of enhancing what we can learn from these demonstrations as they unfold. So I take you back a few years to Oregon, and Oregon in their 1115 waiver only had enough money to provide coverage to a subset of those who were eligible as they were doing a benefits expansion. Because of that, they used the lottery as the most fair way to determine eligibility. And it's useful to think about in this context because every state will have a limited budget for food as medicine, and it will mean either that the state can't offer the food as medicine program to everybody, or the most deluxe version of the program to all who would benefit. Next slide, please. This raises the question of whether doing some A/B testing within states could be used to provide more accurate measures of effect, and most importantly, to test some of these program features before implementing them statewide to inform the decisions on what to scale. One of the reasons we think it makes sense to do A/B testing by a lottery is it's really the fairest way to determine who gets more food as medicine program features given limited resources. And that's very similar to how the folks in Oregon thought about this when they could not extend benefits coverage to everybody who was eligible. Next slide. There are a number of ways you could think about this, but I've drawn this simple schematic. Basic standard implementation looks like on the left, you identify your priority populations, you screen and assess for eligibility, you refer to a program administrator, and they receive the food and nutrition waiver services. Nothing wrong with that, as long as you know what is the most effective way to do that, and that can be implemented effectively. But where we are is there are a lot of open questions about how to do that most effectively, how to have the biggest impact on a population's health. And that's why we propose something that's more akin to what you see on the right with rapid cycle testing, where the top steps are the same, but in essence, the program administrator implements A/B testing. And so you're always thinking about, based on the evidence, we could offer 7 meals a week. We could offer 14 meals a week as a medically tailored meals program. We don't know what the relative effectiveness, cost effectiveness is, but let's find out in a small population before we make a decision about rolling that out throughout the state. So you're constantly trying to learn more and improve on what you're doing as opposed to just evaluating one option. Very similar to how tech companies operate, very similar in terms of how they've gotten better and better over time in engaging people. Next slide. A number of A/B tests you might think about. One question that often comes up is, should we provide FIM support to individual patients or to the household? The household support could have significant benefits, but it adds considerable expense. And so the question is the benefit worth the cost? You can figure that out on a limited basis before making a broader decision statewide. Another example is the amount of FIM support. While providing 21 medically tailored meals per week for a patient who's recently discharged from a hospital would be a nice thing to do if resources were not limited. Resources are limited. So you may want to think about, is the standard approach providing 7 or 10 meals per week? And then maybe there's an enhanced approach, which is more expensive and potentially more effective, where people receive a higher number. Another example might be to couple providing FIM alone versus FIM with an on-ramp to WIC or SNAP, where you really help people enroll. That could be useful in itself. And then a fourth would be around messaging strategies. There's a lot we can test around how to increase program enrollment, and that's an area which I think is really a no-risk approach, which could have a lot of advantages. Next slide, please. So higher on the evaluation ladder basically takes you to where more reliable evidence exists on what works. And the best here would be to do A/B testing both in the early phases and overall, so you really get a definitive answer on what's most effective, what's most cost effective for your population. An alternative that would be very good would be to do a planned staggered rollout at the geographic or provider level, but do this kind of A/B testing in early phases to answer some of these questions about effectiveness, cost effectiveness, before deciding what to scale for everyone. Good would be a planned staggered rollout without doing the A/B testing, but you would lose a lot of information there that I think is readily attainable. Not preferable, simultaneous implementation across all providers' geographic areas, or rollout based on provider readiness. At best, you'll be able to look at what happened in your state compared to other states, but you will have lost the opportunity to have customized that further based on some of these outstanding questions that nobody in the field really has good answers for at the moment. Next slide. So I want to close just by thanking the AHA Healthcare by Food team. We now have about 250 people, many of whom are volunteers around the country who have been working on the initiative on our various task forces and also as grantees. And so we're hoping to really help contribute to building better evidence and helping all of you build better evidence as well. Moving to the next slide, final slide. I also want to let you know the Heart Association will be offering more support to states in 2025, so please stay tuned. And please feel free to either reach out to me or Seth Berkowitz, who will be leading that effort for AHA. Thank you.
Amazing. Thank you so much, Kevin. With that, I will transition us to our state panel to hear how food as medicine programs are being implemented in real time in Massachusetts and Michigan. So we can go to the next slide. I'm fortunate enough to introduce our panelists. So from Massachusetts, we have Stephanie Buckler, who serves as the Deputy Director of Social Services Integration at the Massachusetts Executive Office of Health and Human Services. And from Michigan, we're lucky to have two panelists, including Brad Barron, who serves as the Director of the Managed Care Plan Division, and Catherine Comey, who serves as the Manager of Strategic Engagement and Planning at the Michigan Department of Health and Human Services. So I will start by asking each panelist to give an overview of their food as medicine program, including rationale as to why they pursued services under the specific Medicaid authority being used in each state. And with that, I will turn it to Stephanie to give an overview of what's happening in Massachusetts.
Thank you so much, Stephanie Buckler, she, her pronouns. I'm very excited to talk with you today about our 1115 waiver health-related social needs program. I'm going to go into a little bit of detail on what we're doing, and I can tell you a little bit of the rationale of why we chose the 1115 waiver. I'm not yet seeing the slide, but wait for it to. And there's a lot here, so I'll break down a little bit of the history for you and a little bit of what we see today. So in 2022, the Center for Medicaid and Medicare Services approved an extensive list of nutrition services for Massachusetts Medicaid, which we refer to here as Mass Health. They also approved an extensive set of housing services, which we're excited to pair together, but today we'll focus in the nutrition realm. And this was done through our 1115 waiver, and this is the second approval we have for nutrition services through our 1115 waiver. The first approval came back in 2017, and we've been able to, with this approval, significantly expand, not particularly the service list has grown a bit, but pretty much stayed the same, but where the first set of services came under, for lack of a better term, a grant-based program setup. Now in this new version, we have moved into our managed care benefits. So for a subset of members, they are actually eligible for a benefit of receiving these nutrition services. And I'll go through a little bit of what that looks like now today. So what you see on the bottom is two categories of services. We've broken them down into two categories for the purposes of our nutrition set, a category 1 and a category 2 set. And before I go into detail, the big thing to think about and know here is that what we have done over the past 2 years as we were preparing to launch, which we just did on January 1, 2025, is that we standardize these services. We made them exactly what we do for every other benefit. We said, here's the definition, here are the provider qualifications, here is a provider type that can be used, what dealt with all the rates, dealt with all the coding, everything you need to do to make something come into your benefit. That's what we have been working on, and that's what went live on January 1, 2025 across the state for our accountable care organization members. So that's the large takeaway and one of the major differences between our 2017 approval and our 2022 approval. So getting into just more of the detail of our services, as I mentioned, we have two categories of services in nutrition. Category 1, we really consider the food. We have home delivered meals, food boxes, and food prescriptions, and we break them down by whether they're medically tailored or they're nutritionally appropriate. And then we have the second category of services, which are our enhancements, if you will, nutrition education classes, nutrition counseling, and kitchen supplies. And we have a generalized rule that an accountable care organization cannot have a Category 2 type service without a Category 1 service. We don't want our members just getting nutrition education and then not being able to get the food to utilize with it. So those two things go together. Now, another layer in this really exciting time of moving this into the benefit is that we only have so much expenditure authority on the federal side and so much funding on the state side. So in order to make this work, we created what we called a supplemental list of services, which is all these health-related social needs nutrition services. And we told our ACOs, you need to pick at least one on the housing side and one on the nutrition side. And we have most of our ACOs picking at least 4, maybe somewhere around 6 to 8 for most folks that you can provide. And once you choose which ones you provide, then it acts like a regular service. The standards apply. If a member comes and they're eligible, they must get it. So this way we were able to balance a bit of our budget, but still offer these services statewide along the standard lines of a benefit. So a little bit of a unique way of dealing with how do you provide these across the state, but also move it into the benefit. A little complex, happy to answer any questions about it, but really exciting to move it forward in this way. So we are moving right now into this place. We had previously been into the grant place. We are currently diving really into the data from our 2020 to end of 2024 services, and really excited soon to release a lot of information and really amazing results that have happened with nutrition. But before then, we can share that we served about approximately 38,000 members over the 4 years with about 80,000 services during our time in the flexible services space. And now we're moving over to this HRSN space. And finally, before I send it over to my state colleague, just a mention of why we went with the 1115 waiver. Massachusetts has long since been an 1115 waiver state. Previous to these two experiences with the 1115 waiver and health-related social needs, we had been using this for a different but similar housing program. And so it made sense in our overarching plans for what we were looking to do with accountable care organizations, as well as with health-related social needs, to put these two together. And we have been able to, I would say, very successfully utilize the 1115 approach to our advantage to move it towards a covered service. With that, I'm happy to send it back to you, Amanda.
Perfect. Thank you so much, Stephanie. That was a super helpful overview, and we'll get into some more specific questions after. But we can go back one slide and pull up Michigan's overview slide, and I will pass it off to Brad and Katie to give an overview of their Food as Medicine program, which is under in lieu of services authority, and take it from there. Thank you, Brad and Katie.
Thank you, Amanda, and thank you everyone for joining us today. As Amanda mentioned, I'm Brad Barron with the state of Michigan, and I'm joined today by my colleague, Katie Comey. So the Michigan Department of Health and Human Service, and as I would wager everyone that's on this webinar today, understands that health is about more than just medical care. We know that the research shows that as little as 20% of health outcomes are driven by access to and the quality of your health care, while the social and economic factors can drive up to 50% of an individual's health outcomes. And as you heard earlier in this presentation, there is growing bodies of evidence that indicate that we can improve the health and control healthcare costs with investments in health-related social needs. With this in mind, Michigan launched a statewide social drivers of health strategy, and Medicaid has been critical to this effort. We recently re-procured our Medicaid health plans in Michigan, and in that we included a suite of new requirements that related to addressing health-related social needs. So for example, we encouraged our standards for requiring screening for health-related social needs and monitoring whether enrollees receive services to address identified needs. We increased our requirements for health plan contracting with community-based organizations and ensuring member awareness, as well as assisting with applying for other public benefits. We included new requirements around community reinvestment within the regions that Medicaid health plans serve. And we are allowing Medicaid health plans to offer in lieu of services to address enrollees' nutrition needs. So the introduction of in lieu of services will allow Medicaid health plans to pay for nutrition services that have been shown to improve health and reduce future need for medical services. We decided initially to focus on 4 nutrition-related ILOS in Michigan. So this includes 2 meal services, a healthy food pack service, and a produce prescription service. We chose to focus on food and nutrition because, as has been mentioned all throughout this presentation, there is a pressing need in all of our communities, particularly in Michigan, and because there's also a very strong evidence base showing that investments in that food and nutrition materially improve health while also reducing any unnecessary healthcare costs. So one of our key goals in Michigan was to make sure that these services were available to enrollees as soon as possible. Unlike our Massachusetts colleagues, we determined that the ILOS authority provided by CMS would help us to achieve that goal as compared to other authorities, which can be more complex and take a significant amount of time to negotiate. With that, I believe I will hand it back to Amanda.
Perfect. Thank you so much, Brad. We'll now move into the panel discussion, so we can take down the slide, and I invite Stephanie to come back on camera. I will start by asking this first question to both states, but how in general would you categorize your implementation efforts thus far? What are some early successes, challenges, and lessons that you would highlight? And I will start with Stephanie.
Sure, thank you so much. It's great to distinguish between what I was talking about of our 2020 to 2024 pilot and today's 2025 pilot. I'll try to give a little bit of each because I know that folks are in different places. So if you are looking to do an 1115 waiver where your program is going to go into a managed care setup, I think square peg into round hole, absolutely a very difficult implementation process, not only, and we're happy to share as other states shared with us, are you looking for codes that will work for nutrition, which we came up with some, and there's a whole, large work stream nationally to do this as well. You're looking for everything from the definition to how providers are going to be defined. So that's really a big challenge, as well as moving your community-based organizations in to become providers. I would say that we were super excited with how our partners rose to the challenge, and that we have over 40 providers that are now considered health-related social needs providers, which essentially are housing and nutrition organizations on the ground. So massive implementation success already there. And happy to, and I'll put in the chat some of the slides and stuff that we gave to those providers. In the other realm, if you are going with, let's do like a grant-based type of thing, which I think is an excellent way to start. And you have sort of the same issues, except with you're implementing it on a smaller scale in a first step. So maybe your community-based organizations don't even know what mass health is yet, and don't know what those those programs are. So it's a little bit more introductory to each other and to working together. So many things to choose from, but I know we have lots of questions.
Super helpful, and I'm sure those in the audience would be eager to see those resources. I will toss the same question over to the Michigan team, but again, how would you categorize implementation thus far? I know it's very early in Michigan. Any just early insights that you can share with the audience?
Happy to jump in here and just share. You know, it's, as you noted, we're certainly in early days, but we are excuse me, when we re-procured the plans and went through this process to add food as medicine into our program, we really wanted to ensure that we were meeting the needs of our stakeholders. So we conducted extensive stakeholder engagement and sought to work closely with our potential partners from the beginning of our planning process. And gaining input from partners was essential to ensure that we were responsive to the needs of our communities. So we're really thrilled about the engagement and collaboration that we've had so far. All 9 of our health plans have been invested in this. Our in lieu of service, potential in lieu of service providers and convening organizations and other local agencies and foundations have provided us with feedback along the way and participated in collaborative conversations along the way. While it's early, again, we're really excited. All 9 of our health plans have indicated that they want to offer at least one of the in lieu of services that Brad had mentioned earlier to their enrollees. We sought to work closely with our plans throughout this process, really to ensure that they and the organizations that they'll contract with to deliver services have the support they need to adopt ILS. I think we've heard throughout today's conversation and have seen some things come through in the Q&A that really highlight the fact that this is not just a quick switch over in activities for Medicaid health plans, healthcare organizations, or the partners that could be delivering these services. So for us, it has been integral to our process to ensure that we have established clear communication channels and feedback loops, provide resources and collaborative learning spaces, collaboration on resource and guidance development and design, and really, I would say, like, patience and flexibility has been one of the biggest factors in all of this to ensure that all stakeholders are moving forward together. We've made it a priority to support the local community-based organizations in Michigan. And so I want to acknowledge, I've seen some questions come through the Q&A about how to ensure that local and community-based organizations have the ability to play in this space in the same way that some of the national vendors do, where they have maybe established systems. And that's something that we've prioritized in Michigan. And so we have been working together with our Medicaid health plans to ensure that we're providing supports to build capacity to local organizations. And some of the ways that we're doing that is by exploring partnerships with foundations and other agencies. That's resulted in the development of our Capacity Connect initiative. This is an initiative designed to empower local community-based food and nutrition providers who have not traditionally delivered services within the Medicaid system of care. And by offering tailored technical assistance, direct funding, and strategic support that's aimed at addressing some of those common barriers that I mentioned, like technology, business or operation practice development, workforce development, outreach, education, convening, that type of thing. Our Capacity Connect initiative will serve to develop and support kind of a community of practice so that locally based in lieu of service providers can enhance their capacity to work in partnership with healthcare organizations and our health plans. Another thing that we have worked through is, Brad noted, we went through the reprocurement of our health plans and included in that the several provisions around social determinants of health and health-related social needs. We included a new community reinvestment requirement, which is a part of the suite of new strategies that we're will allow Medicaid health or require Medicaid health plans to reinvest 5% of their pre-tax profit into the communities that they serve. And while this can't be used to pay for the services like in lieu of services or those food and nutrition services, it can be used to support the Michigan community-based organizations as they develop the capacity to deliver in lieu of services. And we developed our community reinvestment guidance to strongly encourage the health plans in our state to fund activities that will support the ability of community-based organizations to offer ILOS.
Amazing. Well, thank you so much, Katie. So much awesome work happening in Michigan. So the next question, Katie, you spoke a little bit about ensuring flexibility is built into these new services, but how exactly have you built flexibility into your service definitions and design to leave space for innovation as these services are really new? And like Pam mentioned at the top of the webinar, we're moving into a space where nutrition and food is not intrinsically a medical need.
Yeah, thank you for that question. As we reviewed the federal guidance around in lieu of services, assessed services covered in other states, and conducted targeted literature review, and as I mentioned before, engaged with partners across Michigan, that kind of was our kind of launching point for this work. We developed our proposed service and eligibility populations and sought feedback on these items through a request for information process in early 2024 and received feedback from a variety of partners across our state, including health plans, healthcare providers, community-based organizations, health-related social needs service providers outside of the food and nutrition space as well, and several enrollees and their family members. This feedback was overwhelmingly supportive of our proposed services, being in really highlighting the importance to help improve the health and well-being of Michigan enrollees and across Medicaid enrollees across Michigan. And we took that input into consideration to land on the service set definition and the potential eligibility. And so that it initially started in one place and we evolved a little bit over time based off of that feedback and really to ensure that the state had determined what would be medically appropriate and cost effective for the delivery of in lieu of services. But really we built flexibility into our policies so that Medicaid health plans and their service providers that are delivering in lieu of services can work together to design policies and procedures around the administration of in lieu of services in ways that meet the community and enrollees' needs and meet them where they are. So there's opportunity for our plans and the provider networks to have some flexibility. So we've issued guidance and in some places standards and others to allow for that flexibility.
Awesome. And I will, same question to Stephanie, how are you building flexibility into your service definitions and design to leave space for innovation for your ACOs?
Yeah, so a little different. So we've spent the past 4 years allowing a little bit more of that innovation where we had these lists of services and we use a breakfast analogy. So maybe we said waffles and you had waffles in one part of the state and waffles in the other part of the state. And maybe those waffles have blueberries on them in that part of the state and strawberries in the other. But now that we're moving it into and have moved it into our benefit, we need those waffles to either both have blueberries or both have strawberries, and we can't have different. We really got into the nutritional way to be here. So the actual definitions have been standardized, but that standardization has been based on years of work that we've seen and then continually bringing it forward. And now the innovation is bringing it into the benefit. And with that, there's a host of different things that we, Mass Health, will say, you know, this is a rule. And then just like any other managed care policy, it is up to the program that we contract with, the organization that we contract with, to play that out. So how we might say you need to do XYZ screenings and how exactly they're going to pull those things off and how that workflows are going to go. And those are then up to those folks on the ground, and we learn from them.
Well, I will transition us to some of the audience Q&A since there's been so many. I invite Kevin to come back on screen. But this first question's for the state panelists, but how would you recommend a state agency work with food banks or other food-related CBOs to work together to inform food as medicine initiatives and other projects? And also, Kevin, if you have any insight to that from the partners you've worked with, I invite you to jump in as well.
Amanda, I'm happy to share our experience in Michigan, and that we worked with our food bank council in the state and really tried to work with the associations that have a large swath of membership and support advocacy for food bank councils or food banks rather, and farmers markets and other partners that may be delivering services that fall underneath the Medicaid definitions in lieu of services that Brad had presented on our slide. They've been integral partners to us along the development stages and as we go into implementation, in the same way that our Medicaid health plans have been integral partners. Having them at the table just to discuss early concepts has been helpful. And I think one of the things that I take back as a lesson is it's always helpful to even start with ensuring common language, because as we talk about benefits and service provision, the way that our partners in the food and nutrition space talk about it in a different way. And so trying to find a way to meet all of our partners in the same space and ensure that we're speaking the same language has been imperative, and they have been integral to that conversation and helping us shape some of the definitions, as well as helping us shape some of the details that need to go into the guidance that we deliver both to our Medicaid health plans and to the potential ILOS providers in the state of Michigan.
Amanda, I'll just add that in addition to common language, using common measures is really important. One of the key things the AHA Healthcare by Food, our task force on equity and common measures came up with, is a set of common measures that looks at, how do you, if you want to measure a particular construct, what is the most validated way to do it so that we can have apples to apples comparisons of what's working in different populations.
I really appreciate that. And I think, yeah, when doing this work and moving social needs into the healthcare sector, we need to align on language and measures so that data can be shared and used to move this work forward. Another question I know a lot of folks have is regarding payment rate development for nutrition services. So I will ask Massachusetts and Michigan if they can speak briefly to how you're set up your payment rates that must be used, and any advice you would have for other states as they approach payment rate development for nutrition services.
Yeah, this is a big one. Lots of stakeholder engagement as always. We've taken our data from the past number of years, and we're able to utilize that data as a great starting off point. We also needed to really work with our actuaries, just like you would with any other managed care benefit. We do have a fee schedule. The link is going to be, it's in the chat that says additional information, and that fee schedule, some of it is, it's pretty much X amount, and then you can contract with the vendor and the ACO for about 125% above that. So we're giving some wiggle room in there. We had some interesting experiences as we moved through our negotiations with CMS, at which we were hoping to do a risk-based contract, but ultimately ended up in a non-risk-based contract, which I know has been something other states have dealt with, and happy to talk about that offline with folks. But I would say that is my my big like parting message is to try to figure out with CMS what you're hoping for and what they think that they can work with you on, and what they're able to get their partners and their federal partners okay with. And that will very much heavily impact what that fee schedule is going to look like.
Yeah, and then from Michigan's perspective, I think Stephanie really covered almost the exact same process that we went through with, working directly with stakeholders. We looked at as well, looking at some of our other areas of our Medicaid program, such as like our home and community-based services waiver and so forth, that what sort of services that they are offering that are similar, and comparing, doing kind of a comparison of rates. Obviously worked with contracted actuary in this effort. And then we released optional pricing guidance. And so recognizing and for many of the services provided a range depending on some wide variety, and we can also share that resource in the chats. It's available on our website.
Awesome. Well, thank you all. We are at time. The hour absolutely flew by. I saw a last question come in. If panelists could follow up with questions over email. There are so many questions, so the CHCS team will go through them, and if appropriate, follow up with a FAQ or some related document. But we really appreciate everyone taking the time to be here. If we put up one final slide, I will share that CHCS released a report entitled Food for Thought, which brought up some early implementation learnings coming out of the learning series that was published a few months back. Upcoming, we have a health-related social needs resource library launching that'll house all of the related HRSN resources that CHCS has. And just a plug to our partners at Siren and the Center for Health Law and Policy Innovation, who will be hosting a semi-related webinar next week around community reinvestment, which Michigan just plugged their community reinvestment requirement. So lots of amazing work happening in this space.